Good evening. Welcome to SpectraCell's Thursday night webinar program. Thank you for joining us for homocysteine, a marker for neuroinflammation. A copy of tonight's slides and additional resource materials are available in the Learn More box on the left of your screen. The on-demand version of this webcast will be available tomorrow and can be accessed using the same registration link for this presentation. At this time, I would like to welcome Dr. Bernarda Zenker.
Hello, Jessica, and thank you for inviting me to present this SpectraCell webinar tonight. Tonight we're going to be talking about homocysteine as a marker for neuroinflammation. And as we can see here, I want to be covering a lot of material and reviewing some of the biochemistry of homocysteine and the nutritional factors that are important in understanding the metabolism of homocysteine, both in its formation and in its degradation, and some of the consequences of the nutrients or inhibitors causing an increase of homocysteine. We'll be reviewing some of the research on the physiologic consequences of homocysteine and how to manage it. But particularly what I want to focus on, as we'll be talking tonight, is some of the newer discussion of homocysteine and its impact from a neurological perspective with neuroinflammation. Before we get into that particular discussion about neuroinflammation, let's review just a little bit of our biochemistry and some of the implications of homocysteine. As we can see, homocysteine comes from the methionine molecule in the methionine pathway, which occurs inside the cell. It does not occur in the serum. And specifically, you need a molecule of methionine to be utilized by the MAT enzyme in order to make SAMe. SAMe is S-adenosyl methionine, and then SAMe is further metabolized with the AHCY or adeno homocysteine enzyme in order to make homocysteine. So it's a rather simple, straightforward process if everything works smoothly and works correctly, methionine leading to homocysteine. And we know that this is important. Methionine can come from the diet. It is an amino acid rich in animal protein and in high sulfur foods such as eggs, for example, and methionine from the diet can directly foster the development of homocysteine in the body. And as this diagram represents, the reason that it's so important to be aware of in our perspective in talking about inflammation, whether it's cardiovascular inflammation or brain inflammation, is because of the influence of homocysteine on the formation of SAMe and on the formation of glutathione. And we're going to be talking more about both of these tonight and their important roles that we have in the body for adequate metabolism and detoxification, again, coming back to their role with homocysteine. What we know is that there are many things that can contribute to total body homocysteine, both dietary provision of nutrients or dietary supplements, as well as inhibitors that can be a source of inhibition of the metabolism of homocysteine. And so, as you can see in the lower right-hand corner, vitamin status will help to contribute total homocysteine, but so can renal failure and cancer, for example, because they can act adversely on providing inhibitors of the enzymes needed for that methionine pathway to work so efficiently. And so there is a give and take in multiple different areas. We can see cardiovascular at the very top, age and gender, drugs, diabetes, they all have an impact on the determining that total value of homocysteine that we may see on a laboratory report. So let's talk about what we do if we have a high homocysteine, the thought process of what does that mean and how can we interpret it and how it gets back to basic nutrients. Here is a sample of a SpectraCell cardiometabolic report, and I have outlined in red here where we find a homocysteine level. And as you can see there at the very bottom of the page, this particular homocysteine level was 13.7, so it's in that yellow intermediate range, far too high to be comfortable, and we'll understand why by the end of tonight, why this can be so problematic. So on the cardiometabolic test, homocysteine is evaluated, and when I see it higher than 8.5, I begin to worry as to what is happening or what is going on in the body to inhibit the metabolism versus what is lacking. What are we missing that the methionine pathway or the transsulfuration pathway requires in order for homocysteine to be broken down appropriately. And so we'll be talking about those different variables tonight. When we think of homocysteine, we traditionally in medicine have known for a very long time of the cardiovascular problems that are associated with high homocysteine being very, very inflammatory to the endothelium of blood vessels. But we're beginning to see more clearly when homocysteine is high as a marker of inflammation that it is associated with multiple other problems that we are facing in our culture and in our environment. Tonight we're going to be talking more about some of the newest research that has come out with homocysteine and dementia, homocysteine and Parkinson's, homocysteine in neurovascular problems. But let us not forget that some of these other areas, osteoporosis is now being widely discussed as a condition of inflammation in the body. Again, for example, excessive inflammation in the body compensatorily pulling calcium out of the bones in order to try to buffer an acidemia inflammatory state. And in children, we're beginning to see high homocysteine levels with concentration and underachievement, that link, again, getting back to the implications of high homocysteine being the marker of inflammation, regardless of whether it's heart or whether it's brain or whether it's bone, to be looking at homocysteine as an inflammatory marker. So let us review for just a moment about homocysteine and the actual pathophysiology that we see when we're dealing with cardiac implications. And when we know that when homocysteine is elevated, homocysteine as an amino acid can directly injure the arterial wall. And when that happens, it's like this rupture of the intima there. Immune cells will come rushing in to try to fix the damage, so to say, causing even more inflammation to occur, and then a proliferation of arterial cells causing plaque to form in the vessel lining, and that leading on to a progression of cardiovascular disease, atherosclerotic disease. So this is the traditional inflammatory process in the heart that we are accustomed to. But what we now want to focus on is that there are other parameters that homocysteine, elevated homocysteine, has been associated with. Now, and so these next few slides, I just want to put forward as reference slides. This is an article as recent as May 2016, associated with homocysteine and insulin resistance in obesity and obese children. So we need to start thinking about what is triggering this homocysteine, what is inhibiting the degradation of the homocysteine, or what is lacking, what nutrients are lacking, such that in the methionine pathway, homocysteine for some reason cannot be broken down. And might there be environmental toxins causing a stalling or an inhibition of the MTR enzyme, for example, or of CBS, some of these environmental toxins that could be implicated. In this particular study, we're looking at the association of plasma homocysteine with the development of Parkinson's disease. And what we see is that Parkinson's patients with cognitive dysfunction are likely to have higher homocysteine levels. I will make a mention here that some of the newer research that is coming out with some environmental toxins, such as glycophosphates, are markedly implicated in the development of Parkinson's. And we have to ask the question, how is that interrelated with the inflammatory state that is now, that we're beginning to see in the neuroinflammatory state of Parkinson's and neurodegenerative type problems with the environmental toxins. This particular study looks at the amyloid plaque, beta amyloid neurotoxicity, neurotoxic amino acids accumulating in neurological disorders and causing neurodegeneration. Again, getting back to a possible role of environmental toxins leading to homocysteine. And these particular slides will be available. Clinicians can come back and review these tomorrow or next week at your leisure. But I just want to put out some of this research that is now being put forth in these last 5 to 10 years, markedly associating homocysteine and neurological inflammation. This particular article, 2015, from the Journal of Alzheimer's Disease, associating increased homocysteine levels predicting dementia and cerebral small vessel disease and vascular risk factors. So it's not just an isolated document, it's not just an isolated research that's coming out, but in many different journals we're beginning to see this coming up more and more. In this particular journal article, 2016, hyperhomocysteinemia impairs regional blood flow. Could this be the causative, or could this be a causative factor in the endothelial and neuronal nitric oxide difficulties? So we're seeing more and more that it's not just heart that is being involved, but in this particular study they're also noting the renal circulatory diseases having a problem with hyperhomocystinuria. In this particular study, it was a study that looked at the Framingham longitudinal study and concluded that 100% of subjects with a homocysteine level above 14 came down with dementia. I found that extremely disturbing, and a secondary conclusion is that the methylation cycle carries the huge impact of the function and neuroplasticity of the nervous system, and relating how the nervous system, neuroplasticity, and homocysteine and methylation all are interwoven is a exciting discussion to be involved in with our patients, because it's a difficulty, it's a problem that we can do something about if we know the right interventions. And that's why I want to talk about this tonight, because there are very specific nutritional interventions that we can undertake to work with decreasing homocysteine, and also looking at what are some of the inhibitors that we need to be aware of as well. So let's talk a little bit. This is somewhat of a busy slide, but there's a lot here. I just want to present it for reference primarily. And what we see is that when homocysteine is elevated, a lot is going on. And if we start at the very, very top, what you can see is that elevated homocysteine will lead to increased SAW, adenohomocysteine, which can go on to DNA hypomethylation, as it says, and then on out to muscular dystrophy and degeneration. Over to the left, again, fatigue can be a consequence. To the right, increased reactive oxygen species, which can lead directly to mitochondrial damage. And if you just follow some of the arrows around, we see that with the increase of reactive oxygen species onto cytokine production leading to inflammation, and we know that cytokine production then goes on to trigger off so many other cascading events within the cell. So being conscious and aware of elevated homocysteine and the consequences, I think, are great pertinent intervention points that we can do. So we can intervene in significant ways for our patients to help prevent cellular damage and to enable recovery, because a lot of the damage that can be done by high homocysteine can be altered and recovered, perhaps not 100%, but there is recovery, especially when we're working with the mitochondria, knowing how to deal with the mitochondria. So when we look at some of the research, this is just a summary. We know that there are particular consequences of high homocysteine. High homocysteine will increase oxidative stress. As I just mentioned, it can lead to inflammation and mitochondrial damage, increasing buildup of plaque, particularly bothersome in the small vessels, and leading to high blood pressure, increased dementia, and increased metabolic syndrome. Of particular consequence tonight, we want to be talking about high homocysteine and neurological inflammation. And we know that endogenous agonists of the N-methyl D aspartate receptors are involved. There is implication for spreading of depression with high homocysteine. Trigeminal vascular system is implicated, and even just inflammation of the dura mater and the cerebral arteries. Of particular interest for some researchers is high homocysteine implicated with increasing glutamate, which we know is extremely inflammatory, and with the furthering of atherosclerotic plaque. This particular study, published in the American Journal of Clinical Nutrition, showed, if we look at this for just a moment, dementia increases with elevated homocysteine. So let's take a look at the x-axis. The duration of follow-up was over 6 years, and as dementia increased, as the further out in longevity an individual went, and the higher their homocysteine went, the higher their dementia went as well. So we know that if we don't institute intervention to bring homocysteine down, with progression, dementia will result once it gets to that critical level. And as the previous slide mentioned, 100% of individuals with homocysteine over 14 without intervention went on to develop dementia symptoms. Now, here is a long list of deficiencies and problems that are associated with increased homocysteine levels. Some of these will be, I hope, straightforward as we go through some of the biochemistry, but there are a few others that I would just like to point out. We know that B12 and folate are very significant for managing homocysteine, but I'd also like to mention so is zinc and magnesium, and we'll know why as we look at some of the biochemistry later on. If we go down this list, there are enzymes that have to be working in the methionine pathway in order for homocysteine to recirculate and to be metabolized. And of course we know the most famous enzyme in all of methylation genetics is the MTHFR enzyme, and mutations in this enzyme are associated with increased homocysteine, but mutations in the MAT enzyme can also be associated with homocysteine, and perhaps even more seriously involved with the control of inflammation is this MAT enzyme that we'll be talking about just a little bit. But when we look at some of these other factors, for example, hypothyroidism, cancer, cigarette smoking, lots of different medications, and the reason that the medications are implicated is that, so this is a really important point to take home. Many of the medications that we use with our patients can inhibit processes in the body that lead to elevated homocysteine levels. For example, we know that, for example, statin medications will inhibit the development of coenzyme Q10. That's well documented and well known. Well, so can prednisone, for example. Prednisone can be implicated with CoQ10 deficiency. And so I just mentioned this as an example that we have to be mindful of multiple medications causing, even though they may be used for one indication, can cause problems in other areas of the body that may be more disastrous over time, and just to be aware of that. And we'll see this very last instance here is vitamin B6 antagonist. You know, if we are an individual that needs isoniazid therapy, we just have to be mindful that isoniazide is an antagonist of B6 and need to be giving more vitamin B6 to our patients. So being aware of those interactions with medications. In addition, we know that decreased homocysteine can also be present. And here are some a few clinical scenarios in where we see decreased homocysteine levels: pregnancy, youth, oral contraceptive use, hormone replacement, and another enzyme problem, the CBS enzyme, difficulty giving homocysteinuria. And low homocysteine, too low, could also be a herald for some problems in the CBS enzyme problem area in the transsulfuration pathway. So let's go on to the biochemistry of homocysteine. And what we'll see from this is that homocysteine is not in isolation. This is the pathway planner. It's a chart that I'm particularly fond of in that it just brings all the different pathways together so nicely in some of the interactions. And this particular chart was developed by Dr. Ben Lynch, and I use this in lecturing to be able to demonstrate how homocysteine is right here, circled in red over to the right of your screen. But as we can see, it is by no means by itself. And if we blow this up and look more closely, what we can see is that homocysteine, though it's in the middle of the screen, it's right at the junction of two different cycles, the methionine cycle that I have referenced a number of times, and the transsulfuration cycle just below it. But feeding into the methionine cycle is the folate cycle. And all three of these are friends of each other. They flow their nutrients back and forth, and they're meant to get along as good friends, but sometimes, as we'll see, there can be blockages and inhibitors, and almost like a vicious war going on in our body between these cycles. But as we see here, homocysteine is not by itself, and it's right in the junction of these different cycles. So let's talk about the fate of homocysteine. Homocysteine is here at the bottom of the methionine cycle, and homocysteine can go in three directions once it is made. It can recirculate the long way around to the left up through the MTR enzyme and come on back around the full cycle, coming back full circle. This is what we call the long route around the methionine cycle. It can take the short route directly straight north through the BHMT enzyme up to methyl homocysteine or methionine, and then it can recirculate around through the MAT enzyme. Or it can come straight south through the CBS enzyme that we see here, which is the opening to the transsulfuration pathway. So there are three things that can happen to homocysteine, and when homocysteine is abnormally high, we have to be thinking about all three of these routes. Two routes may be fine, but one may be clogged up, or vice versa. So I'd like to present the two major reasons that I consider homocysteine to be particularly important. Homocysteine at the very top circle in red is incredibly important because it is the opening down the transsulfuration pathway, which is where glutathione is produced. And without glutathione, well, let me just say glutathione is the major antioxidant of the body. You have to have glutathione for phase 1, detoxification in the liver, and for phase 2. If homocysteine is clogged and stuck up in the methionine pathway, it's going to implicate our supply of glutathione downstream. And without adequate glutathione, we're not going to be able to have adequate detoxification capacity. The second reason that homocysteine is so important is because homocysteine, again, being recirculated, comes up to make SAMe. SAMe is the required cofactor for every methyltransferase enzyme in the body. We would not be able to live with adequate SAMe. You have to have SAMe in order to metabolize norepinephrine, for example. Otherwise, excessive anxiety results. You have to have SAMe to make melatonin at night. Otherwise, you wouldn't be able to sleep adequately. You have to have SAMe as the cofactor for the PEMT enzyme, which helps to make phosphatidylcholine, from which we get choline to help for the prevention of a fatty liver and for the making of acetylcholine, which is the neurotransmitter for memory. So it's critically important that this whole methionine pathway be functioning appropriately. Homocysteine is important not only for glutathione but for SAMe, and it's looking at the different enzymes that are involved in making this smooth flowing of molecules one from the other to the other is important in trying to figure out what can help our patients, what are the cofactors, what are the inhibitors, where we can intervene. So let's talk more about that. This is just a summary slide here, again, demonstrating homocysteine being so critically important both for glutathione production down in the transsulfuration pathway, but for also SAMe production up in the methionine pathway. And once that SAMe is made, it's exported to all over the body. Every methyltransferase enzyme has to have it in order as the cofactor. I describe it to my patients as like you may have the most wonderful automobile filled with gas, ready to drive on a vacation, but if you don't have oil in the engine, which would be synonymous with the cofactor SAMe, that beautiful car will not function. It won't go anywhere. And as we're talking about some of these enzymes that are involved, it's the cofactors such as the oil in the engine of a car that you need, and you also need really good, clean spark plugs. Or that engine is just going to huff and puff and not work very well. And that would just be an analogy of what I will be talking also about for our inhibitors of the enzymes that will be working for this. So let's go through again and talk about homocysteine going to MTR and then on around the circle. So there are nutrients that affect our homocysteine levels, and I've listed them, and I've listed them several times, and so that we can see exactly where they are utilized. So I'd like to go through this in terms of a sequential exercise, because all of the nutrients that are listed here on the right, methylfolate, B12, zinc, and so on, these are nutrients that can affect our homocysteine levels, both whether homocysteine is elevated or whether it is low. So let's go here, and as you can see, the nutrients needed for homocysteine, I've listed them in green, and we're going to break these down so that you can appreciate exactly where each of these are needed. So the very first, when we talk about homocysteine, you need methylfolate coming in, as you can see it's circled here in red, methylfolate coming up from the folate pathway into the MTR enzyme. There has to be adequate methylfolate coming up from MTHFR. If there is an MTHFR genetic polymorphisms of MTHFR, that can be bypassed by using a nutritional supplement with methylfolate in it. Folic acid won't do the job here. You have to have methylfolate in order to get the folate into the MTR enzyme for it to work adequately. The second nutrient is vitamin B12, and it's that whole cobalamin pathway, again, uniting with methylfolate coming up through MTR. And as we can see here, the third nutrient is zinc. Zinc is the cofactor for these precursors. Zinc is the mineral that we see deficient the most when looking at micronutrient reports. Zinc is critical mineral needed for about 300 to 350 different enzymatic reactions. And when zinc is low, then it slows down all of these processes, and homocysteine will clog up and back up. As you can see, there are two places here for zinc, both the MTR enzyme and the short route with the BHMT enzyme across the methionine pathway. We'll go on now to vitamin B6 at the bottom of the methionine pathway, where homocysteine comes down through the CBS enzyme, but it's only going to do that if we have adequate B6. I have listed here B6 or P5P. Research shows us that approximately 25% of individuals do not metabolize vitamin B6 to P5P, pyridoxal 5-phosphate, very well. And so if you see vitamin B6 impaired, borderline, or low on a micronutrient test, be thinking it may be an individual, one of those 25% individuals that have a difficulty metabolizing B6. And again, it's an enzyme polymorphism that can occur. And in those individuals, we find that they do a lot better with a combination product of B6 and P5P, both some of each, perhaps 25 milligrams of each, or a combination product of both B6 and P5P to assure that that CBS enzyme has the cofactor needed to bring homocysteine down into the transsulfuration pathway. We're going to talk next about cysteine. Cysteine is right to the bottom right of the CBS pathway. Cysteine is required in order to bring homocysteine down. And I want to put a big, strong plug in for cysteine. Cysteine is considered to be the rate-limiting step for the making of glutathione. And so if you're having struggles getting homocysteine decreased or under control, think about giving some cysteine, a very, very important nutrient. And as you can see, just across the hallway there is serine. Serine is also needed. Some individuals won't be able to get their homocysteine down adequately unless and until giving a little bit of serine. Serine may be deficient on a micronutrient test because of some other genetic polymorphisms. Serine becomes glycine and back and forth if all the genetics are working smoothly, but some people cannot convert easily. And so if on a micronutrient test we see deficient serine, then it may be an individual that needs a little bit of boost of plain L-serine by itself in order to provide adequate serine for this metabolism to occur. And then the very last one on our list is magnesium. It's way up at the top next to the MAT enzyme, and it is required as the cofactor, again, the oil and the IgIN, for that MAT enzyme to occur. And when we put all of these together on a micronutrient test, I've outlined in red these different nutrients. And this is the beauty of combining both a micronutrient test with a cardiometabolic test. If on the cardiometabolic we see homocysteine high, abnormal, I immediately look to the micronutrient test for these 6 indications as to what is going on, of where I can institute intervention. And as we can point out here, in the lower right-hand corner, we can see that zinc and magnesium are both markedly impaired. And remember what I said about one of the reasons why homocysteine is so important to look at is because of glutathione. If we look over at the far left in the center of the page, look at that glutathione. It's like rock bottom 0. So as we can see, these analytes are tied together looking at the total picture, and it's well worth assessing in order to institute intervention. And again, that glutathione needed for detoxification. So when I would see something like this, there's a lot we can do to help this individual. What I want us to always remember is that these enzymes are active, but there are specific things that can inhibit or muck up the system, so to say, inhibiting the enzyme function. And I want to just take a slide or two and list these so that we can take a look at it. And by no means are these all the inhibitors, but these are some of the inhibitors that research has shown us. And I just want to put a plug in for understanding. We know what we know. We don't know what we don't know. And as time goes on, we find out that there's more and more that we don't know. For example, let's look at this MAT enzyme. Everything that is in purple on this map are inhibitors. And for the MAT enzyme, too much nitric oxide, LPS, lipopolysaccharide, from gram-negative bacteria, from abnormal pathogens in the GI tract, for example, hepatitis B, hepatitis C virus. And my question, as I ponder how to help individuals, if I know that these viruses can inhibit this enzyme, then I also question, what about Epstein-Barr virus? What about HSV6 virus? Can some of the other viruses that we know, shingles virus, long-term inhabitants of the body, can they also be at play? And it's just will be a matter of time before we know more about this. Here's a second slide. Here's the MTR enzyme documenting some of the inhibitors of MTR. Very important. Lead and mercury can inhibit MTR. And what we now are seeing is a stronger and stronger association between osteoporosis and increasing lead levels. As calcium gets pulled out of the bones, what we see is that whatever lead was laid down at the same time as the bones were being formed, that lead is also getting pulled back out. And so when we see an older individual with perhaps elevating homocysteine levels that may also have osteoporosis, be thinking about lead. Lead being pulled out of the bones because of osteoporosis processes can be working in a secondary capacity, shutting down this enzyme, escalating homocysteine. Mercury also can do this. Acetaldehyde is made by Candida. So if there is a leaky GI tract, inflamed GI tract, abnormal pathogens in the GI tract, precipitating an overgrowth of Candida, remember that Candida produce acetaldehyde, and one of the clinical symptoms that I pay attention to is when someone tells me that they have brain fog. I'm always, my antenna go way up for acetaldehyde. Brain fog and acetaldehyde sort of like our best friends. TNF-alpha. So paying attention to the inhibitors is equally important as paying attention to the cofactors that are needed for these enzymes to work. And I've summarized here nutrients affecting homocysteine levels. Again, the full circle around the circle, we call this the long route circulation, but then there's the short route directly up through BHMT that can also work to our benefit. Some of the nutrients that are implicated for that, trimethylglycine, phosphatidylcholine, again, SAMe being important. So a frequent question that I get in doing some phone consultations for SpectraCell is, how much methylfolate do we need in order to have this methionine pathway working smoothly? If everything is working smoothly, we do not need a lot. And what do I mean by a lot? I rarely give more than 1,000 micrograms of methylfolate. I never, very rarely give more than 3 milligrams of methylfolate. It's just not needed. And so if you don't need a sledgehammer to drive in a thumbtack, I would just say be prudent in the mega high doses of methylfolate, because that can too many folate groups in some individuals can precipitate agitation. And this is a very nice study of young women where high doses of methylfolate are not needed to keep homocysteine levels decreased. So again, 800 micrograms, 1,000 micrograms typically is world's plenty, as long as everything else is also working nicely. For our laboratory assessment, again, these are the 7 nutrients along with our laboratory evaluation of homocysteine that I look at when evaluating homocysteine risk and intervention. So the reference ranges that we typically will see for men, less than 11, for women, less than 10.4, and then nutritional values here. Frankly, I will just share with you, I get worried when homocysteine is higher than 9 because what that tells me is that there may be sludge developing on some of these enzymes, and we don't want homocysteine to get out of control because of its inflammatory capacity. So I ideally like to see homocysteine around 6 to 7, ideally. For testing, homocysteine should be a fasting test, and it can be repeated in 3 weeks or 3 months after nutritional intervention has been instituted. And there are some talk in the literature about testing homocysteine using a post-methionine load, and we do that by giving specific nutrients, looking at high dose methionine, and homocysteine should elevate markedly, should come through the pathway and be decreased. If it is elevated markedly, we need to be looking at some of these potential blockages. Is there enough B6 to bring it down the transsulfuration pathway by the CBS enzyme, or is the short route working? Is there enough zinc to get through MTR, etc.? So now I'd just like to turn this back to Jessica and just ask if there are any questions and a review or discussion of homocysteine and why it's so important with neuroinflammation. So here is a question that I have, and I will read out the question. If homocysteine is higher than 14.9, but CRP, I take that to be C-reactive protein, is low at 0.5, would it be more likely a methylation issue instead of an inflammatory issue as the cause? When very possibly, that makes perfect sense to me, in that if the CRP is low, it's not an inflammation. There's no inflammation there, but the 14.9 being so high, something is getting clogged up in that it's not getting broken down through the transsulfuration pathway. So now the next question, is serine referenced in the long route circulation as phosphatidylserine? No. The serine that is referenced in the long route, I don't know of phosphatidylserine being referenced in the long route at all. I've never seen it referenced. It is referenced in the transsulfuration pathway coming down from CBS, needing serine, and what the literature would say, and what other clinicians that I've talked with that have worked in this area extensively would say, is to use L-serine. L-serine, 500 milligrams, that's what SpectraCell does recommend for helping to boost up serine in order for this CBS. The phosphatidylserine could help a smidge, but it's not going to be as effective as L-serine. But let me just make a comment about phosphatidylserine. Phosphatidylserine is a great nutrient, and it helps to blunt down glutamate, and it's also helpful in blunting down glutamate for sleep at night. And phosphatidylserine is a needed, required component of the lipid bilayer as for the lipid bilayer, as long as phosphatidyl, as well as phosphatidylcholine. And the next question, can you use homocysteine levels as a marker for stroke as it is used in cardiovascular disease? I don't see why not. I know that there is a great deal of discussion about using homocysteine as markers for neuroinflammation, and there are some people that are using it acutely during a stroke process in order to correlate with mortality. So I think it would be quite useful in that respect, just as in a stroke, just as in cardiovascular problems, because the underlying inflammation is the same. It's that inflammation of the blood vessels. Okay, the next question, talk a little more about post-methionine loading, how much to give for how long before testing. With methionine, I know that methionine loading in order to assess for homocysteine is possible. I would give no more than 500 milligrams and then to assess the homocysteine. After that, you should ideally do a pre-level and a post-level of homocysteine, a pre-level of before loading with methionine, and then a post-loading as well. The reason is, first of all, so that you can see the changes. But the other thing is that you don't want to overload the system too excessively with SAMe unless you know for sure these pathways are open for excessive inflammatory processes being set up. You don't want to give sky-high methionine and precipitate an inflammatory acute event. You want to give enough to be able to assess whether there's a change or not, but you don't want to give so much that there's going to be an acute event. So caution is always the best medicine, and prudent. The next question: what types of general patients do you test homocysteine on, or do I test everyone? I use the cardiometabolic report. I use the cardiometabolic report extensively because I love everything that it gives, and homocysteine is one of the components. The cardiometabolic report will tell me multiple diabetic markers, my leptin levels, my adiponectin. It's not just my hemoglobin A1C, but insulin resistance at the cellular level. I love the omega check, looking at the lipid distribution. And so I use all of that when working with an individual for our cardiometabolic evaluation. I look at the lipoprotein A, Lp(a), especially when there has been a family member that has had a heart attack less than age 50. I want to know what that Lp(a) is, and so I'm constantly looking at the total cardiometabolic, and I use homocysteine as a marker for the inflammation of the coronary vessels. So next question: do you consider foods higher in betaine helpful in homocysteine management? You know, some foods higher in betaine can be helpful. I tend not to use excessive precursors for the short route. And here's why. It's because some individuals have genetic polymorphisms in the trimethylglycine dehydrogenase enzyme, and that can lead to a problem. And so I'm cautious in that respect. I do use some, but if I'm going to use intervention for the short route, I try to make zinc. I make sure that zinc is have sufficient amounts, and I'll use some straight choline. And now a final question: do I have other recommendations besides lowering homocysteine that could help if having neurological inflammation? Oh, what a great question. I would look on a micronutrient test. I always think about this. I'd look on a micronutrient test for choline levels, because the myelin sheath on that surround the nerve axons are the primary nutrient is phosphatidylcholine. And if choline is suffering, that's something that is very easy to help to try to fortify. Phosphatidylcholine, those phospholipids to plump up our myelin sheath and our brain cells. The second thing I would say is, look for environmental toxins. Roundup glycophosphate is strongly implicated now with some of the research that's coming out implicating the development of Parkinson's. So I do more testing, also looking for some of those environmental toxins in order to just counsel people to eat organic, good, clean food, clean water, clean air goes a long way. And I think we may be here at the end. Thank you again. Thank you, Jessica, and thank you to SpectraCell.
Thank you so much, Dr. Zenker. It looks like we're out of time for any more questions. Thank you for joining us, and good night.